Hello everyone and welcome to this latest episode on Nick Barlow Radiology, and today we're going to be talking about how to read an abdomen x-ray, and this is response to a comment put in by Kirsten P on the previous chest x-ray interpretation video, just asking for something similar for the abdomen. So I thought I'd do this very short video. It's not going to be as long as the chest because there's not as much to talk about with abdomens, but maybe later we'll do videos on specific abdomen pathologies as well. So without further ado, let's get to it. If you like the video, please subscribe, give us a follow, drop a like on the video as well, please. That'd be very kind, and do share with your colleagues. And give us comments if you want any specific content in future, like Kirsten's done, or if there's any issues with image quality, etc. I'm doing these ones on PowerPoint, but future ones will go back to using the collective minds. It's just because there's more things on these ones to do. It's just easier to do on PowerPoint, but hopefully quality-wise it should be okay for you. Right then, so the role of abdomen x-ray, it has limited value these days compared to what it used to. CT is the gold standard to look for things like bowel obstruction, but patients presenting with acute abdominal pain warranting hospital admission for consideration of surgery, it does play a role. Typically, you do an erect chest x-ray for perforation. We do it erect or upright just because the air rises. Typically, you'd see that below the diaphragm, between the liver and the hemidiaphragm on the right side. As you get more gas build up, it then starts to be showing on the left side and centrally as well. Supine abdomen x-rays may help in patients with obstruction due to adhesions or post-operative patients distinguishing paralytic ileus from obstruction. And we did a video on paralytic ileus earlier, so please see that for more details. CT and ultrasound have higher sensitivity. You'd use ultrasound in pediatric patients with acute abdominal pain to look for free fluid or ascites and signs of appendicitis. You'd use CT in adults to look for perforations, bowel ischemia, and to look for the site of any obstruction. So x-rays, they can show us signs of an obstruction, but not necessarily the cause or where the obstruction's occurring, and that's where CT comes in as a gold standard. For acute inflammatory bowel disease of the colon, x-rays are useful to diagnose and look for megacolon. Colonoscopy is best for follow-up long-term, though, to look for dysplasia stricture or carcinoma. I might do a video on megacolon as part of an ulcerative colitis walkthrough later, but essentially megacolon is where you get progressive dilatation and damage to the transverse colon, and it needs to be treated quickly. If it's not noticed and not dealt with, then it can lead to perforation, sepsis, and death. So it's quite serious. But we can talk about that in another video. Well, abdomen x-rays do have limitations, as I've said. So it's certainly in the UK, and I know we've got a lot of listeners from India and other countries, but in the UK, we have a lot of abdomen x-rays coming through for constipation. There's no correlation with fecal loading and constipation. So what we really should be doing is using transit markers, doing a transit study in these patients. But do tell me in the comments what you do in other countries. I think it's important that we share our practices and be aware of what each other is doing. For biliary pain, abdomen x-rays are indicated, and they only show around 10% of gallstones. For pancreatitis, again, abdomen x-rays have quite limited value. Patients may present with non-specific abdo pain, and x-rays may show associated ileus. It can show associated pleural and pulmonary pathology such as effusion. So it's important to just look, if you do have the base of the lungs included on the x-ray, just have a look for things like effusions. You should do ultrasound initially, really, to look for gallstones, and then CT around 72 hours later to look for more severe complications such as necrosis. In chronic pancreatitis, x-rays are less sensitive than CT, as with most things, but you might see calcifications developing over time within the pancreas on the x-ray. For small bowel obstruction, x-rays can show if it's present, and we'll talk about that when we review the abdomen in a minute, but they can't exclude it, and they can't determine the cause in most cases. So again, that's where CT comes in to confirm diagnosis, indicate the level, and show the cause. In acute abdomen, with suspected large bowel obstruction, CT is the investigation of choice because, again, it confirms diagnosis, level, and cause, which X-rays can't do. But it may occasionally be helpful to do X-ray in limited cases of large bowel dilatation, like volvulus or colitis with suspected megacolon. Again, volvulus is something we'll talk about in another video. Essentially, volvulus is where the bowel twists on itself and becomes dilated due to the air being trapped in that section of bowel, but we'll talk about it in more detail in another video. Just a little bit about areas of anatomy. So it's sometimes, because you've got bowel gas and fecal residue, and because a lot of the organs are of similar density, can be quite difficult to see. The organs do have fat surrounding them, so usually you can see a faint outline, but it depends on the amount of bowel gas and fecal residue you've got going on there. But typically you'd have the liver outline up here. You've got the kidneys, right one lower than the left. You have the psoas muscles here, this triangular shaped density coming down either side of the lumbar spine. And it's important to note this because in cases of aortic aneurysm, where you don't have calcification of the wall, sometimes obliteration of these psoas muscles can be the only sign. So it's important just to check those. Got the spleen up here, sometimes very difficult to see the spleen, but you've got the spleen roughly up here somewhere. You can look for hepatomegaly and splenomegaly, so enlargement of the liver and spleen, but very difficult again to look at really on X-ray. You can be looking at ultrasound and CT for things like that, but occasionally you can see big shadow of the liver coming down below the iliac crest and across. And when we talk about the abdomen, similar to when I was talking on that chest video about upper, middle, and lower zones, we can talk about things in terms of zones on the abdomen X-ray, just to make it easier to understand where things are. So I've labelled these 1 to 9. Number 1 would be the right hypochondrium or the upper quadrant, and we've got the left hypochondrium or upper quadrant at number 3. This area here is the epigastric region. Then we have the umbilical region in the middle. We have the right lumbar region at number 4 and the left lumbar region at number 6. And then as number 1, the hypochondrium. Number 7 would be the hypochondriac or right iliac or lower quadrant. Number 9, left iliac region, hypochondrium, lower quadrant, sorry. And 8 is the hypogastrium. So it just helps when we're reporting to be able to talk about things in terms of these areas, just so that everybody, it's universal, everybody understands then where we're talking about, similar to the chest. So this is a typical abdomen X-ray. Now, sometimes you might not get the base of the lungs on there. Typically, if not, then they should do 2 landscape X-rays rather than 1 portrait. Doesn't always happen in practice, but you want to be able to see the inguinal orifices up to base of lungs, ideally. So really, we probably should have done 2 landscape for this, but anyway, it doesn't matter. So what we want to do first, I always say with abdomen, the only things that we can talk about are bones, stones, gas, and mass. Those are the only things we can really see. I tend to look at the gas pattern first. So we see here we've got cecum region of the colon here. How do we know that this is colon? Because it's got a wide radius of curvature. It's got these thick haustral folds, and it's quite wide, and it contains fecal residue. The small bowel wouldn't contain fecal residue. It's fluid filled. It has a tight radius of curvature, and it doesn't have those thick folds. In the jejunum, it has the thin folds called valvulae convergentes. In the ileum, it doesn't have any folds. So as we look up here, we can see there's quite marked fecal residue all the way down, and some here within the rectum. So I would say there's a lot of moderate fecal loading of the bowel there. Does that tell us that this patient's constipated? No, not necessarily. And it can be normal for the patient to have a reasonable amount of fecal residue there. So again, if you were suspecting constipation, then you'd need to do a transit study. The normal diameter of the large bowel is up to 5 centimeters. So if it's over 5 centimeters in diameter, then it's considered dilated. The small bowel up to 3 centimeters, you shouldn't see more than 2 distended loops. If you see 3 dilated small bowel loops or more, then it implies a small bowel obstruction or possible ileus. Look for any stones. Now, unfortunately, in this patient, the kidneys are around here somewhere, but we've got a lot of gas and fecal residue obscuring them kidneys, so it can be quite difficult to distinguish any stones. Can't see any stones, so it'd be dense calcific opacities, and you follow the line of the ureter roughly coming down here. You can't see any stones there. Typically, sometimes stones will travel into the ureter and then get lodged in the vesicoureteric junctions down here at the bottom, but you can't see anything there. Again, if that's what they're querying, they need to do a CT KUB in order to assess properly. Are there any masses here? So we can see the outline of liver coming down here. That looks absolutely fine. The spleen's up here somewhere, partially obscured by this fecal residue. We can faintly see outline of the left psoas muscle coming down here, and we're not seeing the right because of this fecal residue. There's no obvious increase in density to suggest a mass. Something to be aware of in patients that need a catheter put in. Sometimes you can have distended bladders that come right out here. They are quite dramatic and large. And you've got to be careful not to confuse them with things like ovarian tumours in women, like a malignant tumour. It's just a distended bladder. And if you put a catheter in with those patients, it'll obviously it'll come down. But just something to be aware of. But on this x-ray, we're not seeing any abnormal soft tissue masses. The generalized density of the soft tissues looks similar. We can see some fat planes here at the lateral aspect coming in here. We're not seeing any signs of the perforation, so we're not seeing any signs that air is leaked out. What you'd be looking for there is something called a wriggler sign or double bowel wall sign, where you've got air on one side of the bowel and also on the inside of the bowel. We're only seeing the inside of the bowel wall here. Okay, so we're not seeing that wriggler sign. In cases of large volume pneumoperitoneum, you might see the falciform ligament of the liver coming up here. We're not seeing that either. There's no signs of perforation here. Looking for ascites, sometimes it can be quite hard to distinguish organs anyway, but in ascites, there's a general greyness to the abdomen, fuzziness, because you've got that slight increased density of the fluid, which is masking everything. Again, we can see faintly the outer edge of some of these structures, so it doesn't look like there's any ascites here. And then finally, we're going to the bones, and it is important to check because sometimes certain bony pathology can cause lower back pain, abdominal pain. And see this patient here, on the face of it, looks absolutely fine, but we do have some partial sacralization of L5 vertebra here. Typical symptoms with sacralization is you can get pain in the gluteal region and lower extremities, loss of skin sensation in the thigh and lower back, and localized pain. So patient presenting with lower back abdominal pain, occasionally it could maybe be due to some bony pathology. So always important to point that out. Okay, so a bit of a whistle-stop tour there, only short, but as I've said, we'll talk about specific abdomen pathologies later. I guess the key things to take away for your CPD and reflection on this will be abdomen x-rays are very limited, guys, okay? So do look at your referral criteria depending on what country you're in. In the UK, we use the iRefer criteria with the RCR, and you can only really evaluate bone, stones, gas and mass. And in things like obstruction, you can't really determine the cause. You can't determine where the obstruction is. So those patients need to go to CT. That's a gold standard. But abdomen x-rays still have a preliminary role to play in patients with acute abdomen. Remember the key anatomical areas and the terminology, like I've said, with each area, just so it helps you to describe where things are in the abdomen, which is universal. Everyone will understand it. Typical dimension: small bowels shouldn't exceed 3 centimeters in diameter. Large bowels shouldn't exceed 5 centimeters. I'll add to that the cecum as well shouldn't exceed 9 centimeters. The cecum is larger anatomically. And in older patients, the bowel can sag slightly, so they can look wider than 5 centimeters. So hopefully these patients may have had some previous studies you can check. Another thing to look for, I guess, with obstruction is the bowel. It's almost like you've blown a balloon up. So it'll be obviously dilated. The haustral folds will disappear. In the large bowel, it will look quite pronounced. If there's 3 or more dilated small bowel loops, then it suggests an obstruction or ileus, so they will need to go for CT. And remember, do check the bones. And remember to look for ascites and free gas as well, guys. Okay, so it's not just about the bowel. There's other stuff there that you need to be checking as well. Okay, so that's that for today. Thank you very much for listening. Like I say, if you've liked it, please drop a like. Tell me in the comments what you thought of it. If you think I should be explaining things in more detail, if you want more imaging, etc. And if you have any ideas for future videos, then let me know as well. I'm going to be doing lots of short videos on different pathologies for chest, MSK, and abdomen. So there's going to be lots of content there. And yeah, please subscribe to the channel, guys, and let's keep it going. But for now, thank you very much for listening, and bye for now.